I had to find arguments for the yes position, which was not that difficult. I think the majority of the physicians nowadays treat those patients. We have quite some evidence, mainly from non-randomized registries or single-arm studies, but recently there's even one Japanese study that showed a clear benefit in a randomized trial for patients with exactly this low aspect, so an aspect of 3 to 5. So I could use that in the debate, and for me it was quite clear. I think my opponent had a much more difficult position trying to defend a no position, but she did well. But I think the audience, the majority agreed that, there are some exceptions, of course, but in general, we should treat those patients nowadays, at least in the standard time window, up to 6 hours. You might discuss whether you should still treat patients with a large infarct also in the late time window. There is less evidence, although this Japanese study included also patients in the late time window, but still the other evidence from other trials or registries show that the treatment benefit in low aspects in the late time window is much less. So there you may have some more doubt. I said this Japanese trial, it's called, I thought, Rescue Limit, just published this year in the New England Journal of Medicine. They included patients with an aspect 3 to 5, and I thought even up to 24 hours after stroke onset, but the majority were in the early window, and the treatment benefit was very large, even larger than in the initial trials. So we suspect there is some selection, because I would expect a smaller treatment benefit in those patients. They do worse in general, not treated much worse, so there is treatment benefit, but the benefit is probably smaller. That's I think, my opinion. And at the moment there are 4 other trials ongoing: Tension, Tesla, LASTE, that's the French one, and the SELECT-2, and they are randomized trials. The Tesla trial just finished enrollment of their 300 patients, so we will have the results quite soon. And I would be surprised if they do not find a treatment benefit, but we'll have to see. And then we'll have more evidence. And the other, evidence I talked about were registries like the STATUS registry, the START registry, and the ATIS registry. Those are 3 that published specifically on those low aspect scores, and they all gave the impression, although it's not randomized, that if you treat patients, and at least if you have a successful reperfusion, you will have a better outcome than when you do not have successful reperfusion in those patients.